Welcome everyone, and thank you for joining us for today's Alaska webinar, which is titled Childhood Cancer and the Environment Prevention Opportunities. My name is Sarah. I'm the Media and Communications Coordinator with Alaska Community Action on Toxics, or ACAT. And Alaska is a program of ACAT and Collaborative for Health and Environment, and it's also part of CHE's broader international coalition of over 5,000 individuals across the globe. We invite you to introduce yourself first. Let us know where you're tuning in from, and if you're with an organization. I'll go ahead and enable the chat so everyone can do that now. There you go. But we'll keep it off for the presentation. We have an audience Q&A at the end of the webinar, so for that you can use the Q&A box feature at the bottom of your screen. And we encourage you to send them in early if you like. You'll be able to send them at any point throughout the webinar, and we'll try to get to as many as we can within the time we have today, which is a bit longer than usual. We'll go for an hour and 15 minutes. So I'll jump right into introducing our speakers today and then hand it over to our moderator, Maria. So with us today, we have Dr. Catherine Metayer. She is an adjunct professor of epidemiology and biostatistics at the UC Berkeley School of Public Health. And she's also the director of the Center for Integrative Research on Childhood Leukemia and the Environment. And we have Dr. Mark Miller. He's an associate clinical professor in the Division of Occupational and Environmental Medicine at UCSF. He is also the Director Emeritus of the Western States Pediatric Environmental Health Specialty Unit at UCSF and leads the Childhood Cancer and the Environment program. So thank you both for joining us today. And now I'll hand it over to you, Maria.
Thanks, Sarah. My name is Maria Valenti. I direct the Environment, Health, and Literacy project at Commonweal, and I've been working with Drs. Miller and Metayer for many years, most recently on the Childhood Cancer and the Environment project, now in its third very successful year, which is a national project of the Pediatric Environmental Health Specialty Units, or PESU network, designed to educate pediatric healthcare providers, parents, and caregivers about environmental influences on childhood cancers such as leukemia. The project also educates clinicians and families on practical ways to both prevent childhood cancer as well as to improve treatment outcomes and survivorship. The Western States PESU, based out of UCSF, leads the project. There are 10 champions, one in each PESU region around the country, who work to increase environmental health literacy in this topic. A major project goal has been to improve pediatric providers' knowledge about environmental risks of childhood cancers, which will be covered today, including exposures to pesticides, traffic-related air pollution, tobacco, solvents, and other chemicals. Another major goal is to inform providers and their patients and the greater community about protective factors, which are very important, including the benefits of breastfeeding, a healthy diet, prenatal vitamin supplementation, and early childhood activities, such as attending daycare and exposure to animals, which many people may not know about. Major activities have included conducting workshops and seminars for pediatric healthcare professionals and oncologists, working to establish consultative services at leading health centers and hospitals, and community outreach, with project champions conducting trainings for community health workers and promotores de salud and other community health workers. We have created a wide range of educational materials in English and Spanish to support this project. They're available all free to download. A Story of Health ebook on child cancer was updated recently and offers via the CDC free continuing education credit hours. And new this month, just released, is a translation of the chapter into Spanish with considerable new information specific to Latin America. You'll hear in much more detail about these issues in the following presentations, and I'll turn it over now to Drs. Miller and Metayer.
Thank you so much, and I'm happy to be here today. Our goal today is to provide some insight into our project to educate and activate health professionals, health advocates, policymakers, and the general public to address environmental influences on childhood cancer. Let's look at how did we get here. Children became a focus of environmental health impacts in the early 1990s, really. The first childhood environmental health conference was held in Berkeley in 1991, sponsored by Che. And childhood cancer at that time had been increasing about 1% per year since 1975. However, it was a central topic for these conferences that happened in the 1990s. However, no, please go back. I'll tell you when. Change, yeah. However, in the late 90s and early 2000s, that increase appeared to be flattening out. Okay, next slide, Catherine. Yes, thanks. The one back here, should mention this. We have no disclosures other than that we're funded and supported through the Center for Disease Control and Agency for Toxic Substances Disease Registry, and some support from EPA through that as well, and that the Public Health Institute manages the PACU program. Next slide. So the incidence of childhood cancer had been increasing since about 1990, and it was a center of these discussions and the development of children's environmental health that was developing in the 1990s, and a central topic at our conferences. You can see here the incidence of childhood cancer, though. It went up about 1% per year between 1975 and the 1990s, and then appeared to be flattening out. And during that time period, late 1990s, early 2000s, we had skyrocketing rates of asthma and autism. And so the focus on cancer and children's environmental health really began to take a back seat. And next. As time went on, though, it turned out that was an anomaly in that time period. And really, if you look at this slide from 1975 to about 2011, there really is around a 0.7% per year steady increase in the incidence of childhood cancers. So one goal that we have had with this project is to reconnect childhood cancer as a primary organizing force within children's environmental health. People care about childhood cancer. Next slide. We published our first commentary about the role of prevention of childhood cancer around 2012 in the Environmental Health Policy Institute of PSR. And at that time, we couldn't find any place published either online or in journal articles that used the words childhood cancer and prevention in the same sentence. Nobody was talking about preventing childhood cancer. One roadblock had become arguments about whether any environmental factors were causative. But as time has gone on, have retreated from earlier thinking, next click, about when action was called for. This is a Surgeon General statement way back in 1964. Now this is about tobacco, but you can see what I'm talking about. Although the causative role of cigarette smoking in deaths from coronary disease is not proven, the committee considers it more prudent from a public health viewpoint to assume that the established association has causative meaning than to suspend judgment until no uncertainty remains. Certainly this resonates, I think, for many on the call here, that some precautionary approach is really important, and particularly when we're talking about children's health. Next slide. The American Cancer Society and the National Cancer Institute stance has been, other than a small portion of cancers related to genetics and radiation, we don't know what causes childhood cancers. This stance doesn't recognize the trajectory of scientific knowledge developed over the last 25 years and withdraws from a public health approach found in earlier days. The story that we have to tell really has to start with a brief review of the science, which is the foundation of our translation efforts. For this, I will turn over to my colleague, Catherine Metayer, whose group's work has been fundamental for this field. Thanks.
Thank you, Mark, and thank you, the organizer. So I'll put this graph again, showing data from cancer surveillance data in the United States, SEER data, and just to show again that overall for many cancers in children, the incidence rate has been increasing over the last decades. The lines in red indicates the rates for leukemia. Leukemia is the most common cancer in children overall in industrialized countries. But you see also increased rates of brain tumor in blue, some epithelial cancers like mostly, thyroid cancer. So, overall, a lot of indication from descriptive data that those rates are going up. What's interesting to know, at least for childhood leukemia, is that those trends are different depending on the racial ethnic background of the child. The Latino children are the ones to actually experience the most rapid increased risk in incidence, which, statistically significant trend, when other groups like Black and Asian Pacific Islander do see some increased risk, not significant, and in contrast, reduced risk in white children. So there is definitely some disparity here. And when we see those, increase in a short period of time, disparity between groups, most likely the contribution of the environment at large must be, important to consider. So I just wanted to put in context of the challenges that we face when we want to study risk factors of a rare disease. Childhood cancers are rare compared to adults. So we really challenge with numbers when it's time to study those cancers and subtypes. For that reason, using case control design is the most efficient way to go and study the disease, which means that we have to go back in time and interrogate with different methods to understand what were the exposure back then that may have led to the cancer development. Of course, being a rare cancer and difficulties to go back in time, biomarker studies have been rare as well because it's challenging. And we know, and I'll show you some information about that, but a lot of cancers have fetal origin. So then we no longer have to go back in time during the early years of the child's development, but we have to go, during pregnancy and preconception to understand what happened back then. So we've been fortunate to work with a larger group of epidemiologists and researchers on childhood cancer around the world. Here at UC Berkeley, we were the group to spearhead this consortium, and that has really help us to, provide more robust data to, feed into what we know right now about different risk factors. And here in California, we have developed different ways to assess exposure. Again, going back in time, you will not have the right answer, the true exposure assessment necessarily, but by using different methods, which are interviewing the parents, doing some linkage between where the parents and the child lives and publicly available database, or going in the homes and actually sampling dust in the homes. That is a very interesting media that collects persistent compounds. And eventually having access to some, biospecimen to run biomarker studies. So our group here in California has really tried to diversify the way to assess exposure retrospectively. So I did mention to you that we are faced with going back in time and understanding what are the windows of vulnerability in the progression from initiation to promotion and development of leukemia. Here, this slide is specifically talking about leukemia, and there is some indication that the process is most likely to be a multiple hit process, where an initiating event would occur during pregnancy or even preconception that starts to create some damages of the cells, but eventually throughout the early years of life, additional promoting events will really push this clone into a full-blown leukemia. And the reason why we know it's the case for many leukemia is that the molecular characteristics that have been used at the time of the diagnosis to really understand what type of leukemia the child have been actually found back in the blood spot that was collected at birth. So here we have the same molecular characteristics that were found at the time of the diagnosis have been also identified to be there already at birth. It doesn't mean that all the children went into a full-blown leukemia, but it means that there was a precursor to the leukemia that happened early in life. So as Mark mentioned, the risk of childhood leukemia, childhood cancer have been investigated over the last 30, 40 years more intensively. But I would say, 30 years ago, where were we? It was pretty much sparse data, exposure to X-ray during pregnancy, and some genetic syndromes were pretty much the only risk factors that were established and were contributing to actually a small proportion of all childhood leukemia. So I'm going to be presenting to you really an overview of what the work that has been done. This is by no means detailed because of the time limits, but I will give you a flavor of all the work that has been done to fill the gap. So there are different lines of research that have been investigated around different hypotheses. One being the immune regulation and exposure to early life infection in relation to acute lymphoblastic leukemia. Fetal growth also has been an important aspect that has been looked into different cancers. But of course, today we're going to talk about the environmental exposures that both parents and the child could be facing at home and at work. We've done a lot of work with diet, so I'll be showing a bit of that. And of course, other groups have looked at the genetic and epigenetic aspect to see how the two, all of those can be interplaying. But in terms of looking at the environmental exposure and diet, the driving reason is that many of those chemicals, many of those mixtures, many of the dietary pattern have been shown to either cause cancer or reduce cancer. So in adults, so of course, we also are very interested to know if the same exposure would affect the risk of cancer in children. The reason why we are interested in those cancers is not only because we know that many of them are genotoxic, but many of them are actually disturbing immune regulation, which is, I mentioned to you, another pathway that is really critical for acute lymphoblastic leukemia, for example. And many of those exposures will affect your epigenetic profile. So, a lot of biological rationale to really dive into those different factors. So I will go over a few of them, again, because of the time concern. So air pollution is really important. A lot of children are exposed to a high level of poor air pollution. So this is an ubiquitous problem. Therefore, a lot of childhood leukemia and childhood cancer studies have looked into that issue. Of course, it is always very challenging to assess what is your exposure to air pollution. So epidemiologic studies have been done, all over different countries and looked at different subtypes, looked at different age of exposure, different region, different periods. So, data can be sometimes not uniform, but they still give us a cursor of where the association lays between air pollution and childhood cancer. Many different exposure metrics have been used in terms of assessing air pollution, whether it's traffic density, proximity to industrial source, and air monitors. I will present to you data from a meta-analysis that was done by colleagues from Italy, actually, who pulled data from all over the world, those studies that have assessed air pollution in some capacity. And here I'm going to focus on air monitoring data, which are the most, reliable data possibly. And so what they found is that the level of benzene in those air monitoring, samples were associated with an increased risk of acute myeloid leukemia. And we know that benzene in general, depending on the sources, is associated with acute myeloid leukemia in adults. So we find here the same association in the context of air pollution. They found that the early onset leukemia were, associated with air pollution exposure, and that whether the child was exposed prenatally or after birth didn't really change the risk. Both windows were, susceptible. They also look at Bethadian and find kind of the same trend. What was interesting is that they also ran a dose-response relationship analysis, and here you can see that even at very, very low level of benzene, the risk of acute myeloid leukemia was already, going up and then plateaued. Other groups have looked at different industrial sources of hazardous air pollutant and overlay different maps of where the child was living in relation to where the child was diagnosed with leukemia. And here this is a graph from a study done in Texas, looking at sources of air pollutant in relation to childhood cancer. And what they found is that children living in proximity to the sources of air pollutants in the state of Texas were at a higher risk of hepatic tumors. So where you live matters, whether it's air pollution, whether it's living in proximity to industrial source of those mixture of chemicals. More recently, there's been some concern about oil and gas fracking, and a study was done in Pennsylvania. This is the one I'm mentioning today, but others have been done in the past. And again, showing that living in proximity to oil and gas fracking that emit chemical and radiological, contaminant in the air, but also in the water, was increasing the risk of acute lymphoblastic leukemia. Now, we can be exposed to organic solvent in general, not only through, through the air that we breathe, but also through the work, that you do. And in California, we looked specifically at the different source of organic compounds at work. And here we focus on the fathers. And what we found is that Latino fathers who reported doing jobs that were highly correlated with exposure to benzene, chlorinated hydrocarbon, or polyaromatic polycyclic aromatic hydrocarbon combustion exhaust were at a high risk of having a child with leukemia. We didn't see this pattern among among non-Latino fathers, which beg the question: are Latino fathers more susceptible? Are the level of exposure much higher in Latino fathers, and they don't wear protective equipment? The data could not really get to that, but what we see was really specific to Latino fathers. Of course, families can be exposed to other sorts of solvent at home using paint, solvent, and these data are showing a pooled analysis from the CLIC consortium. So here we have, 3,000 cases to work with and many, many more controls. And so what the data found is that when the parents were asked, using interview, what type of, if they paint before the birth around the birth of the child or after, in relation to having a child with cancer, what we found out, using the pool data, is that when parents were reporting using oil-based paint, or were saying that they actually had a professional coming in the home doing the painting as a rough surrogate of maybe higher level of paint, consistently there was 30 to 70% increased risk of having a child who would develop acute lymphoblastic leukemia. Now, I've been talking about different sources of organic compounds at large. I'm going to shift gears to talk about pesticide. This is a graph that shows, that pesticide is still widely used around the world, and the United States are the second, country that is using the most pesticide after Brazil. We worked again with the consortium, international consortium, to see if parental exposure to pesticide was associated with increases of acute lymphoblastic leukemia. Again, here we have large numbers, 8,000 cases, 14,000 controls. Of course, it takes some work to harmonize the data when you work with so many different studies that have collected information on occupational exposures different ways, but we worked with our colleagues from the International Agency for Research on Cancer that have harmonized those data. And what we found is that when the father was exposed to pesticide before conception, there was a 20% increased risk of having a child with leukemia. We didn't see this trend for maternal exposure to pesticide. And just to let you know that when we also looked at exposure to pesticide at home, using interview again, we found that on average there was a 40 to 50% increased risk of having a child who would develop ALL or AML. So exposure to pesticide, overall, the cursor seems to push towards an increased risk of leukemia. Now, it is difficult to assess exposure to pesticide using interview. So what we've done is to work with another media, is to go back to some of the homes of parents who had a child with leukemia and healthy controls, and collected dust. Dust is a reservoir of persistent chemicals. So the rationale was, maybe, even though it's been collected after the fact, after the child was diagnosed, it still can be an indicator of those exposure 3 to 4 years prior. Children are exposed through, ingestion, skin contact, inhalation. So it's, quite important to look at this in the context of a higher source of exposure and vulnerability to the child. So what we found is that when we measured, over 50 chemicals, and many of them were different herbicides and insecticides. And so what we found is that only herbicides, Dactyl, was associated with an increased risk of having a child with ALL. Other insecticide and herbicide, including glyphosate, the levels of those pesticides didn't seem to increase ALL. Only herbicide. Now, we are exposed to many other chemicals in our homes. So using dust allow us to actually measure those exposure, which usually we can really not characterize well with an interview. So this cartoon is just showing you what are the different sources of different chemicals, whether it's, the way you cook, the way you clean, outdoor pollution can come into your indoors. So, all the lifestyles and different behavior will definitely, increase your sources to exposure to different chemicals. So we measured several of them, including polycyclic hydrocarbon from the combustion sources. We measured flame retardant, PBDEs. We've measured PCBs that are, mostly in consumer products and electronics. And more recently, we measured PFAS in the dust. And all of those families of chemicals, to some extent, have been found to be associated with an increased risk of childhood ALL. So really, using dust as a media is really important to reveal kind of novel association that we could not capture with interview data. So now I'd like to shift the second part of my talk to diet. I've been talking about exposures that increase the risk of childhood leukemia and cancers, but let's talk about diet. I'll be focusing on folate pathway. The folate pathway is really important pathway that really is instrumental in the synthesis and maintenance of DNA. So like many other cancer studies have looked at the influence of folate, we looked at this in the context of childhood leukemia. Again, here I was working with the international consortium to bring not only larger numbers, but bring enough variation in the folate supplementation, prenatal vitamin and folate supplementation, just to be able to actually capture difference between countries really help us to have the power to uncover some association. Should have done this in the United States only during a limited time where the folate supplementation was more common than anywhere in Europe would have been, more challenging to show some association. So this is the value of working with international studies. And here what we found is whether the mother was reporting having used prenatal vitamins or just folic acid vitamins, anytime preconception and during pregnancy, the results were showing that there was a reduction in risk, when you have the odd ratio, which is below 1 and doesn't include 1 in your confidence interval, is an indication that there was a reduction in risk when the mom was using prenatal vitamins. And this worked for any vitamins, but also for folate acid only. What we also looked at is we stratified the analysis by the level of education of the mom as a very broad surrogate of possibly different, lifestyle and dietary behaviors and ability to actually access to prenatal vitamins. And so what we found out is that when the mothers were of really low educational level, the reduction in risk was the most important. Here we saw that those mothers were benefiting the most from having a prenatal vitamin supplementation. In contrast, mothers with high level of education and most likely access to a lot of healthy food, fortified food, and prenatal vitamins actually did not really benefit much of using prenatal vitamins during pregnancy. We looked specifically in our study in California to Latina mothers versus non-Latina white mothers. We have, a large population of Latino in California. And again, what we found is that Latina mothers were the ones to benefit the most here from using prenatal vitamins compared to a non-Latina white woman. Now, you would say, how reliable is this information coming from interview data? We were fortunate to have access to blood spot that was collected at birth. And with colleagues of mine from UC UCSF and USC, they were able to actually measure different methylation markers of prenatal folate intake. And those really correlated well with the interview that we had. So we feel that the interview data, although they may not be as complete and reliable, were actually consistent with the biomarkers that we could measure at the time of birth. Again, using the consortium data, we also had very robust evidence to show that breastfeeding is known now to decrease the risk of having a child with lymphoblastic leukemia. Here you can see the trend. The longer the breastfeeding, the more the reduction. And when the mom was exclusively breastfeeding, when there was no introduction of formula, the reduction in risk was even stronger. So good diet, prenatal vitamin supplementation, breastfeeding, those are both important in trying to mitigate the risk of childhood leukemia. So this is where we were 30 years ago. And now with all this work that has been done in different parts of the world, we have identified many, many sorts of different type of chemicals, whether it's air pollution, paint, smoking, I didn't mention that, pesticide, are increasing the risk of childhood leukemia, when others are decreasing the risk of childhood leukemia when it comes to diet, folate supplementation, and also, I didn't mention this today, but exposure to early life infection are also helping you to build your immune system. I talked mostly about childhood leukemia because this is where I've worked the most, and this is where the data are more robust because it's the most common cancer in children. However, other groups have also investigated all those different factors in the context of not only leukemia, but lymphoma, brain tumors, neuroblastoma, retinoblastoma, hepatic tumors, and kidney tumors. And you can see that there is a cumulative impact of the same factors that have been found to be associated with leukemia. Many of them actually are also found to be increasing the risk of many other cancers. So in conclusion, I would say that as of today, data from different parts of the world are supporting association between several types of chemicals and increased risk of several types of cancers. The data also support reduce risk in relation to healthy diet and healthy supplementation during pregnancy. We are still, dealing with imprecise estimate of exposure, which likely would relate into maybe an underestimate of the true association. So the next generation of studies really now are really focusing on working on biomarkers and especially, taking advantage of the novel exposomic studies that are helping us to understand novel etiologic pathway, but also understand the existing association that we have found with traditional epidemiology. So with this in mind, I'm going to turn it back to Mark, who will continue his presentation on how we use this information for research.
Thank you, Catherine. And you can see the dramatic progress that's been made in the fundamental science behind our work. And so I'm going to walk us through a history of working towards childhood cancer prevention. Next click. We began to work with Catherine's CLICK program, maybe 15 years ago. And I was the leader of the Community Outreach Translation Corps for that program. And when we started, I noticed that there'd be publications that had dramatic findings that were very important, and then they'd get some kind of press, and the press would say, they'd quote the researcher or two from the group doing it about why this was so important and how this should affect our policies, and then they'd have somebody who was a researcher but not part of the group that did the work, who would reiterate that kind of information. And then toward the end of the article, they'd interview a pediatric oncologist who would say invariably, we don't know what causes childhood cancers. So I thought we needed to start by working with that community of experts because they're considered the experts. And we also identified that Latino children were important because in California, at least, we had identified that the rate of increase of childhood leukemia in Latino children was much higher than that in white children. So we needed to address that head on. Next slide. We conducted a survey of around 200 attending pediatric oncologists, fellows, and nurse practitioners. And the majority indicated that they thought environmental exposures were important contributors to childhood cancer. Next slide. But when we went further into that, 90% said that they got questions regularly from parents. At least half or more said they were uncomfortable discussing environmental exposures, and 92% on the positive side said that it would be helpful to have more information. They didn't get any training in their pediatric residencies or their fellowships in pediatric oncology about environmental exposures. Next slide. I have a few examples of the kind of outreach materials we made during this period. And a key one is the Story of Health ebook. And we did one on childhood cancer. It's very thorough. It has embedded videos, links, etc., and offers 3.75 continuing education credits from the CDC for physicians, nurses, health educators, pharmacists, and others. We've had over 25,000 users for registering for continuing education credits for this. Now, we've just recently translated this into Spanish and done a great deal of updating to include a lot of information and studies relevant to Latin America. Next slide. We created a photonovela type comic book that was specifically designed for use by promotores de salud, community health workers in that community, for introducing the idea of environmental exposures, impacting either positively or negatively risks for childhood cancer. Next slide. For the last 2.5 years, we've gotten funding from the CDC through Trevor's Law, which specifically is directed at improving response to childhood cancer clusters and environmental exposures. And this has allowed us to greatly expand our work as seen in the next few slides. Next slide. We did training. First, we trained one champion from each of the 10 PACEUs in the country. And then we conducted a couple of workshops in Wisconsin where we had pediatric oncology fellows and nurse practitioners from around the country. And we had a very thorough 1.5-day introduction to this work, including communications strategies, because identified concern in that community is not wanting to make parents feel guilty. So how do you do that with this work? Next slide. 80% of the attendees said that they made changes to their clinical practice 3 months after the attending the workshop. More than half had already shared information with parents, and 80% or more said that their approach to answering families' questions had changed. Next slide. Again, 3 months after training, there's a couple of feedbacks. Has your perceptions of environmental risks changed? I was completely ignorant before I did this. And a key takeaway, there's a lot to be known about the link between childhood cancer and the environment that is never discussed in formal education. Next slide. We created a fact sheet for use. You're trying to make things easy for clinicians to be able to hand out materials. We developed a reference guide, and we created an ongoing newsletter, which you can subscribe to, that comes out about every other month on childhood cancer and the environment. Next slide. And then we, for addressing the Latino community, we had this major involvement with community health workers, or in that community, promotores de salud. We developed a whole curriculum. This is an example of that in a flip book that you can take out to a community center or a house. And on one page, there'll be just like we're doing slide presentation here, but here's a physical presentation, and one side is for the learner, and one side is a script for the educator. Next slide. The next big jump what we're able to do since we had this new funding was to work on the development of consultative services. Next slide. And this really came from a mother and patient advocate, Lexi Zissou, who said that, when their daughter was diagnosed with Wilms tumor, that nobody on the staff really knew anything about environmental health issues. There was no intake history. They didn't ask or give any particular advice, either during or after treatment. And she was left to do her own research. So, I really like what she says. Exhausted patients and caregivers rely on our doctors, nurses, and child life specialists to guide us through this unique hell. I would vastly have preferred to collaborate on that area, and rather than to have to arrive at their own environmental health conclusions. So why wasn't there anything like that? And we decided, yes, we would help to make a consultative service. Next slide. Our first effort was at Baylor College, where we did a training, and then this last month we did or in February we did a training in Kansas City. So we now have these programs developing in at least 2 major centers, and are looking to develop that further. And another major change was we've now begun to have information that environmental exposures, both early in life and post-treatment in childhood cancer survivors, impact outcomes. Exposure to particulate matter in children treated with chemotherapy doubled their risk for respiratory disease hospitalization. This is well after their treatment. These are in survivors. And that particulate matter is associated with an increase in CNS and lymphoma mortality at 5 and 10 years after treatment. Next slide. So what do you do with this? Well, clinicians or others, there are things that people can do to reduce exposures. One would be to follow airnow.gov, as people are becoming used to here in California with all the wildfires. But and on days that the air quality is poor, you can spend more time inside, develop a clean air home, and try to adjust your activities accordingly. Next slide. We can teach about how to make an inexpensive quality HEPA filter for those that can't afford to just go out and buy one. And this is an example, a Corsi Rosenthal box. Next slide. So when we started working with Baylor, and we had a full day training there, and after that, Omar Shakil, a pediatric oncologist that we're working with there, did a faculty survey. He found, similar to our earlier information, that 70% of the providers were not comfortable discussing environmental risks. But we were very happy to see that almost all said that such a service would be helpful and that they don't anticipate any problem with using the service, and that they would use the service. Next slide. And here's from advisory council. After hearing of the plan to develop consultative services, families reached out and expressed thanks for this topic. One family saying, "I know many families have talked about it in the halls of the unit, but we could not find answers to this topic anywhere." Next slide. The most recent thing, we've begun to work with Prep for Gold and other foundations. Next slide. We've been involved in both of the first two historic childhood cancer prevention symposiums. I mean, just think about it. We went from, our early involvement where nobody even talked about childhood cancer prevention anywhere to there's now been two national conferences on the topic. Next slide. Of course, we do all kinds of outreach to the public, clinicians, et cetera, podcasts, videos. We have our newsletter. We've been in blogs, and et cetera. Next slide. I'm going to come back to something that Catherine talked about, folate. Folate in preconception period, early pregnancy reduces the risk of childhood leukemia. And you saw, vitamin consumption can reduce ALL risk by almost 30%. Actual folic acid supplementation, 50–60% in some communities, like the Latina community, as Catherine showed. Next slide. So how relevant is this today? From NHANES, we know that about 15% of women of pregnancy age have suboptimal folate levels, and that's a little bit higher in Latino women. Next slide. So, part of our education and everyone, and I think certainly in prenatal care and ideally in preconception care, you'd talk about the not only need for prenatal vitamin, but just a healthy diet and fruits and vegetables. And this program, I point to the bottom line here. Start protecting your children before they are conceived, because there's good evidence from the studies that preconception and early in pregnancy, even before you would normally be seen for your pregnancy in a clinical setting, is important time windows. Thanks. Next slide. Of course, all of these things, they're co-benefits. Air pollution is related to preterm birth and asthma and respiratory and neurodevelopment. Pesticides similarly, and inadequate folate is associated with neural tube defects and autism risks, et cetera. So, and on the positive side, breastfeeding has all kinds of other positive impacts, besides reducing childhood cancer risk. Next slide. So, question, this is Ayana Johnson is a climate activist, but she asks this great question: what if we get it right? What does it look like? And we really need to address, all of these different things, both social and nutritional and chemical risks, in order to see, the impact that's possible. Next slide. We'll pass on this. Let's go to the next slide. I've been saying, well, if we can show, which has been shown for many things, that childhood cancer is increased by certain exposures, then the assumption is that childhood cancer will be decreased if we decrease those exposures. But I've had to use other examples of decreased air pollution and how that had a positive impact on asthma or respiratory development. But I just recently ran across these couple of papers. This one, childhood cancer incidence trends in association with U.S. folic acid fortification. So in the late 90s, we started supplementing or fortifying grains with folic acid. And as a result, this looked at that data, and post-fortification decreased Wilms tumor, that's a kidney tumor, by 20% in the United States. And here's another primitive neuroectodermal tumors. They were decreased by 40%. And click. Next, yeah. In Ontario, Canada, they saw a 60% decline in neuroblastoma. So we can do things on a, it's not only that people need to be careful, and they can make their own choices, but systematic programs can make a big difference. And I think particularly this was important with folic acid supplementation because you got to everybody by fortifying grains, and you got to them early, which we already had identified as an important time window. Next slide. And just want to thank our many collaborators and supporters. Thank you.
Thank you, Mark and Catherine. That was that was a lot of information to cover. We do have several questions. I would encourage people to go to A Story of Health. It's got a lot of details about some of these, a lot of what was covered in the broad strokes by Catherine and Mark as well. So we have a couple of questions on exposures, actually all of them. So this would be for both of you, maybe mostly for Catherine. What effects are you seeing related to exposure to cell phones and screens?
Yeah, so, my team has not, studied this in detail. A lot of work has been done actually in Europe, mostly focusing on brain tumor because of the proximity of the exposure to potential non-ionizing radiation. So it seems that the most recent large multi-country study that was done in Europe doesn't really show strong association between exposure to cell phone and brain tumors. So I am, again, I'm not the expert in this field. I haven't done, work, but it seems that, again, exposure assessment is always challenging in this situation. But the data are not strikingly showing, increased risk of brain tumors.
Okay, thanks. So here's another one on radon. With so much exposure to radon, why is there not as much information about radon exposures and elevated health risks? Especially, this was a person asking about for states known for higher levels like Pennsylvania and other states where there's a lot of radon.
Yeah, so again, my field is not radiation, so but I'll have Mark maybe, supplement. But my understanding is that again, the data are not maybe consistent, at least between studies that have been done in Europe, more recently in Switzerland, and here in the United States. So it's not because I'm not mentioning it, it's not an issue. But I think the data are still kind of, uneven. But Mark, you can maybe
I think there's no question that radon is an important exposure in many communities with very strong links to lung cancer risks. And as Catherine mentioned, for example, there's been studies in Switzerland looking at radon in childhood cancers, which were negative, and they have very high radon levels in Switzerland, so that that raises the question. I know that 20 years ago, radon was assumed to be associated based on some studies, but it's just the strength of that. It hasn't really followed through over time. And I think it's very important for us to address radon exposures. Whether or not that will reduce childhood cancer risks, we don't know, but it certainly is related to childhood exposure to radon is related to adult cancer risks. So,
Yeah,
so
lung
that's
cancer.
quite important.
I may ask, if we're talking about radiation, data are getting pretty strong in terms of exposure to CT scan, where the, doses of ionizing radiation are quite high compared to just traditional, X-rays. And more studies are coming out showing an increased risk of leukemia, brain tumor in relation to, exposure to CT scans. So I would say definitely this is where there is, high dose, potential for high dose, and more studies are coming out showing increased risks.
Okay, thanks. So here's a question about how can you explain the rising incidence of childhood cancers while exposures have decreased based on what we're getting back from like the toxics release inventory, some of banning of the worst pesticides, et cetera, PCBs. And I guess my first response would be all exposures are not equal. And maybe you can
And I would say not
elaborate.
every child is equal, and maybe what we have to look at is to really focus on those communities that are still exposed to high level of air pollution, that are still exposed to, water contamination. So maybe overall, yes, it could align. It doesn't align, but if you look at those communities that are the most affected by pollution burden as a whole, social deprivation as a whole, I think you will still, question whether there is a link between those exposures and childhood cancer. So yes, in the best world, one would like to see a nice reduction overall of those cancers, but I think the picture is more complex in terms of the complexity of who gets exposed, and and then the genetic susceptibility to be able to adjust to that, and really the gene environment interaction studies have not really been available to date, most likely because of the challenges to bring large numbers and exposure assessment and genetic studies, in the same population. So we're still being challenged with that.
I'd like to make a couple points. One is that Catherine showed this actually very important slide about benzene. So, and she made this point, but it may not have been clear to everybody what this means, that there's a very steep dose response curve in the low dose range, and then it flattens out. So that most of the impact, this is similar to how lead works with neurocognitive impacts. It's most of the actual impact is at relatively lower doses. So you might reduce your exposure some, but you're still really getting the most impactful exposure. The other thing is, we didn't emphasize it as much in this talk, is these things are related to vulnerable time windows. So, at some times, it's maybe not your overall dose over a long period. It's what you got on that day of gestation, or so a relatively smaller dose of exposure at the wrong time may have just the same impact as what we see as larger exposure over a longer period of time.
And what I may add to in terms of those chemicals that have been banned and that therefore supposedly are not longer in the environment. We're not finding this. We're finding that when we measured all sort of chemicals in the dust, we still find dioxide that has been banned, you know, decades ago. When we compare the amount of chemicals that we find in the houses of Latino, you know, Latino families and non-Latino families, the profile is completely different. What we find out is that the older your home is, the more chemical you're going to find into your home. So even if you were not the one to introduce those chemicals when you moved in, they've been around for so long. So yes, maybe they are not being available on the market anymore, but we still have traces of those chemicals inside the homes.
Yeah, and that includes not only the kinds of chemicals that you usually think of as forever or very long-lived chemicals, but you know, for example, pesticides, which are types that are more transient because they get under your carpeting and your carpet pads and they're in a dark area or whatever, they last much longer in that environment and have a potential long-term exposures too.
So here's a question about how prevention can help mitigate environmental exposures. So are there studies looking at those kinds of effects? So for example, folic acid supplementation and environmental exposures. Is there a, you know, is there an effect, a positive effect that will help mitigate the environmental exposures? Or are they interacting or modifying or synergistic, whatever?
Yeah, Catherine might want to weigh in too, but you know, I don't think that we have that kind of data about interactions like that on childhood cancer. That reminds me of, you know, similarly though, folic acid, for example, is early in life is related to autism risk, but it's particularly the combination of exposure to certain pesticides is related to risk, but that's mitigated if you have adequate folate, or you're more likely to have it if you have inadequate folate, as well as the pesticide risk. This is for autism risk, though. Catherine, I don't know if you have.
Yeah, I mean, I would say we don't have the data specifically, but at least we know there's a main positive, you know, a beneficial influence of having folate supplementation. So whether it works directly, you know, either there's a direct effect of you know, folate on the cells, or whether there is an indirect effect by, you know, mitigating harmful, you know, harmful effect. I think we don't know. I don't have the data for that. So I would say that the fact that we know that folate supplementation, healthy diet, breastfeeding is reducing the risk, I think, again, it is enough to make sure that, you know, women and young children will benefit from those.
Okay, here's something on, what about microplastics? Any information on the microplastics and childhood cancer?
No, not that I'm aware of. Um, Not that I'm aware of. You know, phthalates in relation to certain endocrine, you know, organs have been looked at, but even this is difficult to really quantify level of phthalates. So I would say those type of of emerging concerns are real. To design the right study to, you know, the good study to assess that is still challenging. I'm not aware of any studies. Mark, are you aware of any studies?
No, but like you say, phthalate and endocrine adopting chemicals related to, this is later in life, testicular cancers or something like that. Yeah, yes, but not in childhood cancer work that I'm aware of yet. I think it's probably coming, but not yet.
Okay, here's a kind of a tough one. Is there a critical window of time period for exposure to chemicals during pregnancy, which is related to the severity of childhood cancer? You touched on that, Catherine, with the multi-hit
Yes, and so,
slide.
we're working with our experts in methylation, Joe Wimmels, and indeed, fetal development is such a complex mechanic that anything that can go wrong at, 1 day or 1 week of this development could have actually profound impacts. I think that the first weeks of fetal development are most likely critical. For example, when it comes to folate supplementation, we've done some studies to actually measure folate species and other nutrient in the folate pathway. We measure those at birth. And we find there is no difference on whether the levels of folate and other compounds in the folate pathways, there's no difference between a child who had cancer and a child who did not. So that tells us that the window of exposure is not the last trimester, is not the last week of the pregnancy, but the early gestation. So I think there is a lot of information in terms of the biology and the early demethylation, remethylation during the fetal development that points to the very early, early windows, early weeks of the gestation.
Thanks, Ken.
That question included the question of severity. I know for some exposures, so, childhood cancer is not one thing, and there are different types of cancers, and even within leukemias, there are different sorts of leukemia. And, for example, some exposures are related to increased risk in the types of leukemia most seen in children between 2 and 5, which tend to be ones we're very successful in treating. But sometimes it's much greater exposure in the much greater impact on the risk for infant leukemia, which is a very severe form of leukemia for which our treatments are not nearly as effective. So it can play out in that way too, as far as severity.
Well,
All
there's
right, thank you.
on-
Yeah,
on this-
we're kind of almost at the end of our time here, and there's just one more question that I think might be useful to just address very briefly is how will your activities be affected in the near future now that environmental health is being, well, the questioner used the word neglected, but we know what that, I guess we all know what that means.
Yes, well, the last month have told us already. The next month will tell us more. I am fortunate that my grants have been renewed as of 10 days ago.
Excellent.
I wasn't sure about that prior. So we'll see. I think there is no doubt that it's going to be challenging. It was already challenging, to be honest, to fund research when it comes to the etiology and prevention is really challenging. Most of the fundings are going to treatment, and this is a trend that we have not been able to reverse. So I would say even with previous administration, it was becoming extremely challenging to do the work that we're doing.
Yeah, previously we had looked at the percentage of funding for research that might contribute to findings that would be related to something we could do in prevention. So etiologic factors other than genetics, as an example. And, somewhere in the 1 to 3% of childhood cancer research funding goes to even this very broad spectrum of something that might conceivably tell us something about etiologies and might contribute to our ability to prevent children's cancer. So that was before the current time period.
Yeah. Well, you can, I just from all the questions, we can see that prevention is at the top of the list in everybody's mind. So hopefully your work will help push that forward. Thank you, Catherine and Mark.
Thank
Really
you.
appreciate that.
Thank you so much.
Yeah. Bye.
Thank you all. And just to wrap up really quick, a recording of the webinar will be available on the ACAT and CHE websites in the next day or two, and it'll also be sent to your emails. Thank you to our speakers for joining us today and sharing this very important work and your insights. Please keep an eye out for more CHE Alaska webinars on the CHE and ACAT websites. And thanks everyone for tuning in. We'll see you next time.